Hello, and thank you so much for joining us today for the webinar Modern Methods for Updating Your Dental Hygiene Department. We would like to thank Tracey Lennemann for being with us today and our sponsor for making this lecture possible. Please take note of any questions and comments you have during the lecture, as they will be addressed by the speaker at the end of the presentation. Without any further delay, please help me welcome the expert herself, Tracey Lennemann.
Hello, good evening. Thank you for turning into the webinar tonight, for those of you who have managed to make it online. For most of you, you'll probably be tuning into this a little bit later. So yeah, and then so looking at it at a different time. So anyway, I'd like to thank you and thank KaVo and Care for asking me to present this presentation again. It's kind of back by popular demand since it's packed with lots of information. So they've asked me to redo the course again. So that's been really great. So hopefully I can help you with some information. We're going to talk tonight about modern methods for updating your dental hygiene department. And what I'd like to do is just to hit on some key points for you in a practice, whether you're a dentist or you have a dental hygienist who comes in, if she comes in part-time or full-time. This is kind of a team effort of what we're looking at, and these are some informations that you need to be up to date with your hygiene department. So first of all, and these are just some statistics from the UK, but it turned out that half of the population has some sort of gum disease. We know this through many different studies that have been done. We know that at least they say there's another study that showed us 15 to 20% of the world population has it. I would expect that to be a lot higher in more developing type countries than more Western type countries. 83%, another study said 83% of people have some sign of gum disease, with 2/3 having visible plaque in at least one of their teeth. And then 20% of dentists actually don't check their patients' gum at checkups. Dentists, I found, if you're a dentist too, I tend to see that dentists tend to focus on the restorative aspect. And with dental hygiene and oral hygiene, we're trying to focus on the preventative aspects. What can we teach the patient at home to do so they can actually prevent and reduce the amount of inflammation and infection that they have? So it's very important from both aspects to do complete checkups with the patients when you're examining them. Therefore, our role as a dental team in oral health care is first and foremost the education of the patient. Why, what, how, and where. Why has this happened? What's going on? What can we do to stabilize the problem or fix the problem? And then also to help the patient. And then we get into the prevention and the treatment of it. But the most important thing is that the patient understands why this is going on. So let's look at some things from prophylaxis to non-surgical periodontal therapy. Look at some different steps to success. Okay, just kind of a checklist for you. First of all, let's look at what we know. We know that all dental diseases are associated with plaque. Okay, there's some patients that can have high levels of plaque with very little problems, and other ones that are just fantastic at their oral home care, but they still have high inflammatory reactions of this. So it is still plaque control is a critical part of what we do for DK and also for gum disease. We know that our plaque is now starts in biofilms as communities of hundreds of thousands of species of bacteria forming. We know that biofilms travel through the body. They're associated with different parts of the body. We inhale it, we ingest it. We can actually transfer it through kissing or using a spoon, things like this. We know through the different research that there's also various groups of bacteria affecting them. We know that we have our red complex, which is actually our bacteria that actually lives in the tissue walls. So for those people in higher risk groups and have these bacteria that are a higher risk of the gum disease. And then we have also a varied of other bacteria that has to do with plaque and things. And we know all of this. And we know what's most important is this periodontal systemic link. And this is where I look at it from the perspective, these associations actually help me determine what risk category I put my patient in. So do I put my patient in a low risk category? If they're low risk, I'd say, oh, great, you can just come once a year or twice a year for half an hour. Or are they high, middle risk, or a high risk? I try to get my high risk patients coming at least every 3 to 4 months. It doesn't have to be an hour scaling, it can be a half hour for biofilm management, but it's still important to help these people understand you have to come a little bit more often because you're in a higher risk category. And the reason they're in these higher risk categories is because they have one or more of these factors, these multifactorial connections, being local factors, primary host, and systemic. Let me just go through that very quickly for you. Our local factors, of course, are those things, environmental predispositions. Those are something that we can do something about actually in the practice as a team, as working with the teeth, the calculus, the tartar. Tell the patients it's tooth stone. This is important to help the patients understand how to limit the amounts that they get through good oral home care. But that's our job, is first of all to remove it, the stain removal, plaque and biofilm management, and help get any kind of inflammation and bleeding reduced through the instruction of better oral hygiene habits, and then get them coming back regularly. A lot of people think, oh, I just need to have my teeth clean, but they have to understand this is actually kind of a medical treatment too. The mouth is the door to the body. I've always said that. I've always told the patients that. It is your door, so what happens and what goes through here will affect the rest of your body. So it's important to keep this area very clean. Local factors also are things that we can influence. So it also has to do with their lifestyles. Are they smoking? Do they have a high stress diet? Very fatty diet? Do they drink alcohol? How is the bad breath? Bad breath is obviously a sign for some kind of active pocketing. We know 80-90% of bad breath is because of pocketing and the bacteria in it, the anaerobes. The poor home care, or maybe they have just a really high fear of dentists and they don't go to the dentist, and therefore then it contributes to this entire other factors. But these are things we can influence and try to change. Coffee, tea, and red wine. Now, this is something we always kind of focused on just because it's unsightly and we don't like it, and the patients don't like it, and they come in for that. But actually, if you look at them, they're not contributors to the disease. They just are hard, deposits on the teeth we need to clean up. So it's very important that you educate your patient about the differences of them. And this is more of kind of, I tell the patients, a superficial, take your car to the spray car wash and just spray all the big chunks of mud off of it. But to get a really good clean, you've got to get in there by hand. So it's kind of, I help to associate that with it a little bit. Smoking, huge risk factor. Anybody who smokes goes automatically, for me, almost to the high risk category, depending on how many cigarettes they smoke a day. It is a number one causative factor for gum disease too. And so it's very important to educate your patients about this. They have found in through studies that somebody who smokes 5 packs of cigarettes per year has an increase of periodontal pathogens by 18%. So, or 18 times the amount of periodontal pathogens. So, and it also weakens their healing process. So it's very important to talk to them about smoking. And the issue came up last time about e-cigarettes. It is something to kind of think about recommending using e-cigarettes for helping them to stop smoking, but have some caution on that because they are finding some of these e-cigarettes explode. So that's kind of a very tricky issue. I'm not a smoker, never been a smoker, so it's something that, and I just ask the patients about, do you want to stop or not? Believe it or not, there are a lot of people who love to keep smoking. So I just educate them and said, okay, you love smoking. This is something that you enjoy. Just to let you know, you're in a high risk category, so we need to bring you in more often to keep your mouth clean and healthy, as long as you continue to do this. So find a little flexibility with your patients is always good. The influence on the teeth, the rest of the body on the teeth, or how they all interrelate, from the sugars to the dry mouth to poor oral hygiene. People who have diabetes tend to be a little bit more overweight, and they really have to watch their diets properly. Their reduced healing capacity is also there. Sometimes it leads then also to heart and circulation problems, and it's just kind of a snowball ongoing effect. So it's also important to explain how your teeth relate to your general health also for your patients. And this is how to motivate them a little bit to come into the practice and see you a bit more often. And then there's also a group of patients where the primary host factor is the medications they are taking. So how is their body responding to this? There's a huge list here of primary host factors who have been shown to have an increase in inflammation in the body. So hence, if you have more bleeding gums or you're taking these medications, you have more plaque on your teeth, you're not having proper home care, you could also get enhanced bleeding inflammatory reaction because of the medications you're taking. So these people also automatically go on a high risk category list for me. And don't forget the natural medicines. There are a list of them where people say, okay, I'm taking the natural medications rather than a synthetic. Well, they are still altering. They do alter your body. So it's not just the synthetic ones. The natural ones will actually have a tendency to have the body have more inflammation or more swelling if, or say an exacerbated inflammatory reaction is what you're having to the plaque. So these people need to be also in your higher risk category group. Um, Also, you can see that the body reacts. This is wound healing, slow wound healing, infection from diabetes. Rheumatoid arthritis is another one with the swelling and the joint pain. And then you also have some forms of edema, which also can be affected. And then you can see the periodontal disease. So they all kind of hang together in these factors from a host response. And then we work into the actual medical predispositions. Now, these are things we cannot change, but these are things we have to keep into consideration for the patients, from the diabetes all the way through the list to the cancer treatments. Diabetes being the number one, it is a bidirectional disease, so that means the more plaque and the poorer the oral hygiene is, the more difficult it is to regulate the diabetes, and vice versa. Once you sometimes get the patients cleaned up, then it's actually easier for them to regulate their blood sugar. So it's not with everybody, but it's actually a first step. And all of your diabetic patients should be on a 3-month recall with you, definitely, for sure. Cardiovascular disease, we know that's interleukin 1, more a risk for P. gingivalis, so increased risk for heart disease. So anybody with any kind of heart problems should also be on your high risk category and coming often. And remember that periodontitis is an inflammatory disease. It's an inflammatory reaction, inflammatory disease, and help the patient understand that. So one of the first things you can do is with your patients is through integrating the patient into the practice. Remember your consultations and always explain to the patient, why has this happened? Why are your gums like this? Why is this happening? Why are you losing bone? Why are your teeth movable? Once they understand the why, then it's a lot easier for them to process the information. Once you then, you're showing them with flip charts, and then you're starting to talk about, this is what we need to do to get you stabilized, and help them integrate them into their own treatment. And then you can go into how you're going to do it and your technologies and stuff. Always focus more on the quality instead of the quantity. And then you're going to have long-term patience for that. Build a trust with the patients and help them understand they're investing time and money into their own health. Your dental assessments, just briefly go through these from your updated medical health history. Every year, take one. People change, people get older, they have different medications, different problems, hospitalized, things like this. Always make sure you're getting new health histories. And I'll go back. And then also x-rays. I think sometimes you can take too many x-rays. I tend to like to take them for perio cases. I like to take a full mouth set at the beginning, and then maybe a year, 2 years later, just take maybe vertical bite wings to see how everything's looking, to see if everything's stabilized or if we've missed anything. Always check the mobility, the tissue conditions, and the pocket and probing depths. Plaque indexes if you want, disclosing to show the patients if it's a harder case. Remember, we have two different dental diseases in the mouth. One disease is decay. We're dealing with streptomutans and a whole other group of bacteria. And then but the most important thing is with decay is that looking at the age categories who have the decay. Mostly it's mostly of the child are mostly highly affected by this, especially with sugary drinks and sugary foods, and also till they're about mid-20s, and then they start getting more into the periodontal problems, and then the decay will start showing up again later in life with root decay. So it's important to kind of assess where the decay is coming from. You can also put the decay patients on your low, middle, and high risk categories also, for telling them how often should they come in, and as far as the treatments options available. What KaVo has is this Diagnodent pen, and it's a pen where you can actually early recognize early decay to give you some kind of values. It's got about a 60-40 false positive, so you have to make sure the teeth are clean, and then I dry them off with a cotton roll. But it's a great way to motivate the patient and then also give you some idea is this a stain, or is this something that could be working into something else? And then for that point, then you can work the patient in to treatment of sealants and fluoride varnishes and things like that. Another great one is also the Diagnocam, which actually it's an x-ray without an x-ray that looks deep into the tooth with a camera, and you can actually see interproximal decay, which is quite a nice combination of the two, the Diagnodent for occlusal surfaces and then Diagnocam for visual, looking at proximal surfaces. And this is a great way to get early decay without having to put the patient through x-rays and things like that. It's for better diagnostics also. When you have the patients who are, say, the kind of the school of thought is that if they have one cavity a year, they're automatically in a high risk. And then there's a very long list of risk factors for decay, and you can find those on the internet everywhere. I think ICDOS and some of the other programs have those, where they tell you all of the different categories to help you decide, is this a high risk patient or a low risk patient. And then what Care has is they have some different products for cleaning and for fluoridation of these surfaces and of these areas using sodium fluoride. And then also there's some varnishes that, especially with the children, you can put those on 4 times a year for a varnish. So that's one part of the disease is our decay, but another one for mostly the adults, we're focusing on the dental disease, which is the periodontal disease, through the periodontitis, periodontosis, however you like to say that. Your main bacteria are P. gingivalis and all of these other bacteria. Those are what they call keystone pathogens. We know there's hundreds of bacteria, but these are your keystone ones, in high quantities of people with also systemic problems and these other risk factors and categories. So what's important is to look at what our goals of non-surgical periodontal therapy is. First of all, having a patient come every 6 months for half an hour and doing a scale and polish is not proper. It is not a proper periodontal therapy. It's just a light superficial scale and polish. And this is where I see patients who have gone through years of scale and polishes for half an hour, especially here in the UK. I'm in London right now. And so, and that's what I'm seeing, but I'm seeing a lot of supervised neglect. So what I'm seeing is a lot of pocketing. So above it looks fine, oral hygiene's great, but then you're getting 6, 7, 8 millimeter pockets with chunks of calculus in it. So these are things that you have to make sure that you're not doing supervised neglect. Start doing your exam, start looking subgingival, start looking to see if why are we doing this. Explain it to the patient and say, we need to bring you back for more treatment because something's going on down below. So our goals are obviously to suspend the inflammatory reactors, reduce, modify the biofilms, maintain a healthy periodontium, and get the patient to actively involve themselves within these treatments, and obviously do their homework. So here's what we have to do is we have to disrupt the biofilms, and I know most people focus on the biofilms, but what's also very important is focusing what's underneath too, which on the root surfaces. So it's kind of a combination. What we want to do is we want to first of all restore a bacterial balance, because that's what's happening when somebody's not healthy at that state. They have a strong imbalance of bacteria of gram negative, gram positive, and we want to restore that balance. So let's go a little bit of back to basics, what you can do for your better diagnostics, for your overall assessments. Remember, there are 4 parts to the periodontium. We all learn this in school. Sometimes we kind of forget what we do and why we do it. Remember, we have the cementum, the alveolar bone, the periodontal ligament, and the gingiva that sits over it. And what we want to do is we want to restore this area. So through our dental exams and diagnostics, it's very important that we're looking at what's going on below those gingival margins. Taking the current x-rays is fine. A panorama or an OPG, that works as a temporary solution. It just gives you a nice overview. It's also good for cancer checks. But for perio, I like to use the individual PAs. And even, like I said, you could do a vertebral bite wing and then you get the whole set there as long as it's not too deep. If it's too deep, then I'll just do an individual PA of those areas. But I can see the calculus. I can see the pocketing, some horizontal, vertical defects. I can see what's going on in there. And it's easier for me to actually explain that to the patient too, why they need to come back in for another hour or 2 hours for this cleaning. So don't forget to take some full mouth series at the beginning for these patients. Look at the periodontal status. Which was the last time the patients had a periodontal treatment done? Maybe they've never even had one before. They've just been going for scale and polishes forever. Take a look at that. Grab some history of the patients. And then when you go in for your exams, look at the inflammation, the hygiene, the mobility, the furcation, the recession. Look and test all these things. And I give the patient a mirror. I let them hold a hand mirror and they do this with me. They look at this with me and I show them what I see, that what's healthy and what's not healthy. So you're integrating them into your treatment and you're involving them into that too, which is a great motivating factor. What type of bacteria? That's very important to know. Is it more hard deposits or more soft deposits? We know harder deposits are easier to remove. The soft deposits are more where you're going to see the inflammatory reaction. By the way, that's a lot. That's more fun to remove, isn't it? I know we're a little bit crazy, but that's fun because we know we're going to see direct results with that one. Plus, there's not a lot of huge inflammation and infection. It's mostly where the bacteria and the biofilm sits on the tissue. Whereas somebody who has more of an exacerbated inflammatory reaction, this is going to be a harder case to treat. The patient have to have absolutely perfect home care. Plus, you have to make sure there's no cement under these crowns and everything. So it's a little bit of a more difficult case. Look for the 7 signs of the periodontal disease. There's the bleeding, the red gingiva, the swollen inflamed gums, increasing pocket depth, bone loss, mobility, spaces between the teeth are migrating, and halitosis and bad breath. So every single exam, every single patient you see, you should be looking at these 7 signs of periodontal disease on those. What are our 2 goals of periodontal therapy? We actually only have 2, and I consider periodontal therapy part of the prophylaxis because the prophylaxis is the beginning phases of that. So first of all, the inflammation, reduction of the biofilm. That's a given. That's what we're all doing now these days. We want to restore bacterial balance through the chemical and mechanical changes. And the next one is we want to get a reattachment, a regeneration. And that's where we get into the root planing. I'm getting into here and that. But you have to have the bacterial balance restored at first. And this goes with better home care and stuff before you can start working deep into a pocket. So what we want to do is we want to establish this PDL and get a reattachment of it and get long junctional epithelium, because when bone is gone, it's gone. But as long as you still have a tissue and papilla, you could get long junctional reattachment, and that's part of what we do too. So for your prophylaxis and periodontal therapy, let's just go into some different aspects, so the different steps of it, just to see if there's something new that you're not using and you might like to see, or if just a kind of a checklist to see that you're doing what you should be doing, put it that way. So we're going to focus first of all on the removal of the hard deposits, then go into the soft deposits, remineralization, oral hygiene, and then we'll come to the recall. For your scaling, we start off usually with power debridement, so power scalers. We have our different types of scalers on the market. We have our Soniflexes from KaVo. That's an air scaler that is loud when you turn it on. It goes, ee, but it has an oval movement, so you can use all sides of it. We have the next a little older generation of the magnetostrictives, like the slimlines, and those are where you're going to get more of an elliptical movement. You can also use the sides of them. And then your piezo is a relative technology from the 90s, and that has a side-to-side movement of the tip. So you only use the sides, just like you're using a scaler. So there's very important to use whatever product you have in the most efficient way that you can use it. So really understand how those tips move. The Soniflex here, we're going to show you a video here quickly, video 1. And this will show you, we're going to switch to it, of how I fulcrum very closely on the tooth or next to the tooth I'm working on. I'm still just using the side of it. You never ever want to use the tip of any of your ultrasonics. I'll turn it around, and I use it just like I'm going to use a hand scaler, and I do take it subgingivally as far as I can use it, and in small 1 to 2 millimeter movements, there you can be a lot more effective with it. And then also working on trying to get the stain as much as I possibly can get off at the same time with using that. The tip that I actually recommend is the number 5 tip. I think the angulation is the same one in the video, is one of the best tips to use if you're using the Soniflex Air Scaler from KaVo. What also they have is these plastic tips. They're out of PEEK plastic, which are actually appropriate for around implants. So you can do your implant biofilm management that way. And I also use it for around crown margins and crown edges, just like you see in this picture. I'll take it around the edge of it. And it's very gentle, so to make sure there's disruption of the biofilms, and then also there's any cement left over and anything on that area, but it's a great tool to use around those. This is a great one to use if somebody has veneers, that you can use it and the tissue is a bit puffy. You're never going to want to use a metal tip. This is where this plastic tip works brilliantly for that. Then there's also for your implants a lot of hand plastic instruments for that. You can actually use them around the crowns and the veneers also. Remember, an implant is different than a normal tooth because you don't have a PDL and you don't have a lot of bleeding in that area. You have direct into osseointegration, the bone to the implant. So therefore, the biofilm management is a very, very critical issue with implant maintenance. Make sure, and this is what everybody does wrong, but make sure you find that little card that came with your ultrasonic, or ask the company for another one, and measure your tips. If you're missing the first 2 millimeters of your ultrasonic tip, it's doing damage, because it works through the movement of the first 2 millimeters, and if those are missing, you're absolutely scraping and you're damaging that tooth. You've got to make sure you buy new ultrasonic tips just like you do hand scalers, because they will wear down and you don't want to have that damage. And then that's where it hurts the patient. It sounds a lot louder and you're not going to be as effective with them. So check all of your tips. Now we combine hand scalers and ultrasonics. I pretty much only use ultrasonics when I have like big chunks and masses. I'm a hand instrument. I'm old school. Been doing this for 30 years. It's my 30th clinical year this year. So I like the fine tactility of using hand instruments too. So it is a nice combination of where little bits and pieces here that are black that you cannot get off with ultrasonics, you are able to get them off more with your hand scalers. So don't forget about using your combination effect. And then of course the Gracies for the difficult and the deeper pockets, and root planing. I like to rinse with hydrogen peroxide 3%, or if you have peroxyl is also good. I like to rinse and get that bubble effect, and then I'll take a little brush, interproximal brush, to kind of get out all the granulation tissue and clean that all out there. Care has some nice plastic instruments for your implants that won't scratch around the implant superstructures, or if you have a nice long neck of the implant from titanium, that is a great tool to use for that. And like I said, you can use these plastic tips also on normal teeth. Say somebody has a lot of recession and very sensitive root surfaces, or around the crowns, you can use these plastic instruments for those areas too. It's good for removing the biofilm. Not heavy scaling, more of biofilm management and new calculus or new Togger. And so what you can do also from your DiagnoDent pen, you can actually, there's a tip, a sapphire tip that you can actually go into the pocket afterward. And as it works on decay, this one works on perio and calculus to tell you if there's any calculus left in the pocket or anything after that. So that's a nice kind of all-around tool for decay and for the for gum disease too, for calculus removal to see if there's anything left in there. Your next section is now you get into, once you've done kind of the hard deposits, we're going to get into the soft deposits and then biofilm management. You're getting into the polishing effect of it. And remember, biofilms build up as soon as you're finished working. So our whole idea is just disruption of these biofilms. So bringing them into individual planktonic forms and not in this cluster of a commune. And so we're trying to break those up as much as we can and reduce the amount of them. One of the best things we have on the market is using air polishing. If today you're still not using air polishing, get yourself air polishing unit. It makes your life so much easier. Remember, we're using air polishing for stain removal, for plaque and light stain removal. We have biofilm management. You can have implant maintenance with it. It does, some of it will help to start remineralization of the tissue of the tissues and of the root surfaces. There are a whole bunch of different types of powders on the market today, and you'll see from your normal sodium bicarbonate, which is the salt. Now, this is one we've been trying to get away from for years because there's a lot of other better products on the market other than this sodium bicarbonate that are a lot better for your tissues, they're a lot more effective at removing the stain and with less damage on the teeth. And so here's just a list of some of them. Your sodium bicarbonate, you only want to use those for super gingival, and where they're great is if you're doing sealants. So those of you who are therapists or even the dentist, before you're doing a sealant, the sodium bicarbonate works great. You don't have to use a brush or pumice anymore. You just spray it on top of the teeth, rinse it, it dissolves quickly, and then you can just etch and start doing your sealant. So that's a great one for that. Your calcium carbonate, you're going to use super gingival at the moment, but they're round pearls. I'll show you here the calcium carbonate as round particles, so therefore they're not the shards that you're going to get in the salt crystals. You're going to get more of a rounder, more uniform delivery of the product. They're rounded particles, there's no salty taste, no sodium, and it has a nice little whitening effect to it, which is really great, and it comes in different flavors too. So this is a fantastic alternative than using alternative to using the sodium bicarbonate. What KaVo does have is they have the pearls in different flavors now, so it's a lot more tastier than just having it be nothing. Okay, so let me show you what you have to make sure. Now, this is a super gingival product. We're going to look at video number 2, and this is going to show you how to use it. You want to just keep it, you can use 60 to 90-degree angles. You don't want to go into the tissue. That's a different one at the point in this moment. You want to, for stain removal, you want to keep it more at kind of a 90 degrees at the tooth and just do some circles around it. You can angle it into the proximal areas to use it this way, and that's where you're going to have a better effect with using your air polishing in that way for stain removal. Remember, after you're done using anything for super gingival, you should also hand polish afterwards or with a cup just to kind of smooth those surfaces. What we do have now is for the biofilm removal in the pocket. This has been around since the 90s, the late 90s. We have glycine, which we call perio, and that's a product of a building block of protein, amino acid, and you actually can put them straight down into the pockets at a 45-degree angle into the pockets, and this is where you're going to blow your biofilm. You can see that it just goes in here, this clump of biofilm in here, and you just kind of blast it away. And what you have to make sure is that you hold your tip about 4 to 5 millimeters away from the sulcus when you're using it from an external tip, not the probe tip that goes in, but the other tip, because if it's too close, what's going to happen is it's going to splatter back up in your face. So you always want to have a little distance there so the delivery of the powder will go into the pocket properly. And then you're going to suction across from the other side of it. And what's interesting is what the ProphyFlex has now is a special, this probe tip, this ProphyFlex perio tip, where you actually can go deep into a pocket with this tip and very specifically get in there for the biofilm removal. Because we know just from a normal tip, you can only get about 5 millimeters or so. This one will take it all the way down. And it actually, just like a probe, you can see we have a deep pocket in here. And this tip will actually just slide right into there in that area. So here's now video 3, kind of showing you how I'm gently inserting this tip into the pocket and just blowing very gentle. Sometimes if you want to just do bursts, that's fine, but you're going to take it very gently around the edge. It seems like it's really strong, but it works just fine. It's enough pressure, and it's been tested, enough pressure to actually break up all of those biofilms. And I actually, just not for the deep pockets, I love to take it around the crown margins. I thought it did fantastic, and around my implants and everything. It was great. Now remember, we're using the perio, the glycine in this product. You don't need to rinse it afterwards. It is absolutely brilliant and gets in there really, really nicely for the cleaning. It's perfect for sensitive areas like this, recession areas, pocketing areas with stain here. Now remember, when you're removing, if you want to do biofilm, here's your tooth. If you want to do biofilm, keep your tip 45 degrees into the sulcal area, into the sulcus. That's going to get you the biofilm subgingivally. If you want stain, then move your tip 90 degrees and let the particles hit the tooth. Oops, there you go. Hit the tooth directly, and then you're going to get more stain removal. So stain removal 90 degrees, 45 degrees into the pocket for biofilm. And those are just some couple tips to remember. And you can remove stain also with glycine. It does come off. Here's another area that's perfect around the implants, recession areas that work great. And you just take it really gently around the edges and just go around the edge very lightly, and it'll actually take all of that nice biofilm within that subgingivally where that implant is off very nicely. Okay, and here's a bigger implant maintenance case. It's an older case. It's not the prettiest case in the world, but hey, the lady's 80 and it's been in there for 30 years. It is a fixed one, but you can remove it, and you can see that she's had lots and lots of years of recession on those. You can see the threads of the implant, but those are solid, and there's absolutely no pocketing, and very healthy tissue. She does a pretty good job of cleaning. This is an indication where you could use something like the glycine on that area for maintenance. The next thing for polishing, what you're going to take into consideration is when you're polishing the teeth with a prophy cup. I love this Duratech tip from KaVo. It's an oscillating tip, so it actually helps to polish the teeth and use the prophy paste in a uniform manner. When we have the spinning ones, you can actually, they can go too fast, the pressure can be too hard, you can actually heat up, and you can actually damage the tooth with using a regular prophy cup. And this is a way for it to oscillate and go on quite nicely around and give you a nice polishing of that. So these are some things to keep in mind when you're using the polishing cups and the prophy cups, is to don't let it heat up and don't let it go too fast and too hard for that. There are different cups for different hardnesses. You have the light blue ones, which are more for that really friable, fine, thin gingiva, and you can use the darker blue ones that are a little bit harder from care, that are more of a healthier, thicker gingiva. And then they have some shorter ones to reach kind of in the buccal areas if somebody has a real tight, small mouth, okay, which is nice to have the variety and the variability of the prophy cups. They have different prophy pastes for polishing. Keep in mind of what your patient has, where their problems are. You have a whole bunch of different ones, mint with fluoride. You have also a lighter one that's not so minty. It's free from flavoring for people that are using under nature paths or they don't like the mint or things. They can have one without it. Then you have the traditional one, clinic in the middle, and then you have one with green apple, but it's and no menthol and no fluoride for some patients that don't want any of that. And then you have one for the kids that's berry burst with fluoride, so it's giving nice flavor in your mouth for those. So those are some nice ones to try. Remember, what we're trying to do is get a nice smooth effect. So here's some before and after pictures of before of some stained areas and then some after, and this is where you're going to get that double effect of using air polishing and using the prophy cups together in the pumice or the prophy paste of using those, and that's going to give you some really good results on that. And then also Care has some new implant polishing paste, which has a very, very low RDA factor of 9.8. So that's perfect. So it's not going to scratch anything. And there's not fluoride in it because you don't need fluoride around implants. And it has kind of a light, fresh mint taste. So that's something for your implant patients. Don't forget your antimicrobials. I like to use these at the end. Our whole idea is to break up these biofilms into individual cells, and then you can hit them with the antimicrobials. I usually like the patients to swish in the before I start the treatment, and then I'll have them swish at the end. For home use, there's various products on the market. I like to recommend Ultradex. It's fantastic. It keeps your teeth clean and whiter, believe it or not, with the I just forgot the name of the product in it. Yeah, the sodium, no, it's the chlorine dioxide. That's it. The chlorine dioxide is a natural product that works to reduce volatile sulfuric compounds. So what it does is it neutralizes it. So it's great against bad breath, and it also helps in reducing staining, which the product works great with the toothpaste and the mouth rinse. Then we also have, Peroxyl. I love to have them rinse with Peroxyl. I tend to be more of a Peroxyl fan than a Corsadil because I don't like the staining of the Corsadil. So I try to go more for something that is not going to stain, but with the Peroxyl, you don't want to use them for longer than 2 weeks because it's just too heavy with the peroxide on the mouth. So, but what's important is kind of look what your patient needs and recommend the product for a short period of time for that product to reduce that bacterial load. At the end, that's what we're trying to do, is try to restore that balance of the biofilm and the bacteria. Okay, and then remember, actively involve your patients in their oral hygiene instructions. I tell the patients, please bring your toothbrush with you when you come and show me how you're using it. And then when they show me, then I can correct them better. Or I'll say, I recommend you go get Sonicare toothbrush or use these little interproximal brushes. What's really important is this active involvement. Don't show them on a model, show them in their mouth and let them practice it. It comes across better. Some of the tips I love these little pick brushes, these rubbery pick brushes. They're fantastic, especially with implant patients. And absolutely, the last videos are Sonicare. And the Sonicare, I still recommend the Sonicare. It's fantastic. It works beyond the bristles. You have to show the patient how to use it though. Just 45-degree angle, light movement back and forth for about 5 seconds, and then move on to the next one. The biggest problem what the patients have is they're just in there moving around like this, and they're not doing anything effectively. Hold their hand and show them how to do it. Take that extra 5 minutes and do that, and you will be amazed at how your treatments and how much success you have and how your treatments are successful after that. And the patients are so appreciative. Every patient I've done that with say, well, nobody's ever told me that before. So just spend that little extra time with them to do that. So I hope I haven't given you too much information or confused you. I'm sure most of you are doing this. It's just kind of good to remember it every once in a while in our head and say, oh yeah, we get into the routine of what we're doing and think, oh, I have to rush through and through. But just stop. If you see you're not going to make it through that patient in that half hour, I always, from the very beginning, take a patient from a half an hour to an hour, sometimes 2 hours. I explain the why first with that flip chart. And then from that, I go in to say, this is what it looks like in your mouth. This is what we need to do. Today, I've got enough time to start you on this, but I'm going to need to see you for another hour or 2 hours. And flow that patient through that way. And then from that, you're going to see more acceptance of your treatment and what you're doing. So remember a step-by-step approach from your assessments. Remember all the products you're using, how to use them properly, review it, make sure your tips, you've measured your tips so you're not using tips that are broken down. Think about what you're doing with polishing. Get some of the new products, try some of the new products from what you're using, and just keep yourself updated as you're going along with this. Remember, 70% of our patients are from referrals. So we want to build these relationships for the patients that they come back, and they also refer their friends. You want to create that, wow, nobody's ever done that for me before, and you want to create that for your patients, and they will stay with you. And at the end, we want happy and healthy patients at the end of that. So, because then they'll know we have a solution for every problem they have. So I want to thank you for your attention. We've got some questions here. So let's move into the questions. Let's see, do you recommend the electric toothbrush? Yes, as you saw, I do recommend the Sonicare. What I like to do is start the patient first of all and ask them, what are they using? Are they using a hand toothbrush or electric, and which electric one? If I always have a hand toothbrush in the practice, so I start them off with a hand toothbrush, teaching them Bass method. Not modified Bass, just your Bass, 45-degree angle, circular movement, and moving along, okay, with a soft toothbrush. So I teach them at least to brush their gums. Most people don't know how to brush their gums. So if they can do fine with that, I'm okay with it. If they're using an electric toothbrush, they need to bring which one they have. As long as you're within that 3 to 4 millimeter range, from my opinion, I'm okay with an oscillating one with the electric toothbrush with the batteries. If they're deeper than that, they're more periodontally involved, they have implants, they have maybe crooked teeth, they have lots of restorative materials in their mouth, I always put them on a sonic toothbrush. So whether it's from the Colgate or Elmex, they have sonic toothbrushes. Sonicare, I love my Sonicares. I usually try to get them more to the sonic toothbrush on that one. The battery ones are okay for children, and like I said, for people who are not really actively involved. They're not my high risk patients. They're more of my low risk patients. Then I'm okay with the electric and the battery ones. Do I recommend using plastic tips for bridges when cleaning? You mean the pick brushes, the plastic pick brushes for in between, or do you mean you're gonna have to text me again? Do you mean the plastic ones? You mean for in the practice when I'm doing it, or for the patient at home? So I need you to clarify that question a little bit. Why a sonic toothbrush and not an Oral-B 3D action? Okay, gonna get controversial here. I'll have to tell you. So how it's gonna work is the different actions of the toothbrushes. You have to understand that the Oral-B 3D action, okay, it's oscillating and then it has this pulsating type thing. Well, any manual toothbrush or oscillating toothbrush, the only way they're going to remove the bacteria is direct contact with it. Okay, so it's going to be on it. So whether you have your toothbrush or you have that oscillating one, where it's touching the plaque is where it's going to remove it. The difference is if you have people with pockets or different areas to go into, these toothbrushes don't get into those areas very well. The sonic toothbrushes, doesn't matter what company they're from, the sonic toothbrushes work with an amplitude and a frequency. So it kind of goes like this. So when you do this, so go ahead and try this right now at home. So when you're doing this, you're going to feel a wind. When that's in your mouth with saliva, with your toothpaste and water and everything, it creates what we call a fluid dynamic. So fluid dynamics is the movement of your solutions. And so therefore it almost works 2 millimeters beyond the bristles. So it's going to get subgingival and interproximal better than these oscillating runs. So if somebody has, 3 millimeters, 4 millimeters, they're relative healthy, they're low risk group, they don't have high bleeding, then your oscillating ones are okay. If your patient has more of a deeper problem, or you've got your implants where you really need to get that biofilm out of there, and we're talking subgingivally or proximally, that's where I recommend the sonic toothbrushes. So hopefully that's helped you to see the difference on that a little bit. Back to the plastic tips you use for implants. You mean the one I just showed, where you can have the plastic tips for the implant ones? Yes, you can use those around bridges too. So go for it. Go around the crown margins, go around these aren't crown, these are my real teeth, but go around your crown margins, go around your implants. Because of these thin plastic ones, you're not going to do any damage. And it's got a little, if you have a prophy flex, or sorry, a Soniflex, it's going to have an oval movement anyway. So it's just going to go gentle around those in the sulcus, and you can take it around the edges of your crown margins, around your bridges. Even if there's a pontic in the middle, you can go around it and you're not going to do any damage with it because it's very gentle and you're getting some great biofilm removement. So yeah, absolutely. You can use those. You can use those not only for implants, you can use those for bridges, you can use those for veneers. For anybody who has really deep recession areas where they're going to have a sensitivity to anything metal, your plastic tips will be great for those. Yeah, absolutely. Your Caviton doesn't have the capabilities of going sub on an irrigation agent. Would you use a syringe afterwards? Absolutely. I take just a normal syringe and I put my peroxyl or my hydrogen peroxide 3% in there in just a normal syringe with a dull tip on the end of it, and then I just irrigate into that pocket. I'll go, if it's a deep 8mm, I'll go into it and irrigate it. What I want to do is, what I'm trying to do with the irrigation at the very end is the bubble effect of the hydrogen peroxide. I like to bring any loose pieces of granulation tissue out. And then I can go with my floss, I can go with my interproximal brushes and clean that all up so we don't leave what we call tissue tags. Now, I'm an old school girl, so I learned in the 80s. So, so what we did was we actually learned to do soft tissue curettage. So we actually cut away the granulation tissue. We don't do that anymore, but you can still, with your brushes and your floss, get away and get out those pieces of granulation tissue, which makes it heal very nicely. And then also you're testing which brush to fit the patient better. And then at the end, I do the home care. So I do the cleaning first, and then at the end, I sit them up, have them rinse really good. I said, all right, this is what you need to do at home to keep it this way. And then I'll show them how to use the brushes and stuff. So hopefully I've given you some good things to think about. Oh, you're an old timer too. We're 40 years. Yoo-hoo, go girl. All right. You know, I never thought I would be doing this for so long. I was more a restorative person. Loved restorative and was kind of into that. I'm Washington State trained and hated perio. And then I went over to Germany and started working in Germany in the 80s, and it was perio up to here. And then all of a sudden, I love perio. I mean, that's my thing. Getting that regeneration, root planing. That's why old school hand instruments, root planing, getting that long junctional epithelium, just getting in there and just helping these patients. And it's absolutely incredible what we can do using some old school technology and techniques that we learned back then, combined with new technology, and it's great. But remember, just tell the patients, explain to the patients why, tell them why you need to do it. And I try to do 2-hour appointments with the patients if I can. Or sometimes if they don't understand what you're going to do for 2 hours, then I'll start them with an hour and bring them back for another hour for that. Good question. Metronidazole gel in the perio pocket. I used to use this long time ago. Many years ago, we were doing that in the pocket. But before you do that, you've got to test which bacterial strain you have, because metronidazole not going to work on all of them. So that's where you're going to have to do, I like to do the Hind tests or one of a bacterial test to tell me which is it. Do I have a red complex? Do I have AA in there? Which bacteria I have in there. So if you're going to do something like that in the pocket, you better do the test first to see which bacteria you've got, because it's not going to work on all of them. So, and you don't necessarily need that. I find that at least 70% of the patients just need a really good root planing, scaling, great home care, and they're fine. It's that 30% that they're going to have the swelling, they're going to have the pus, they're going to have that. Then you're going to have to start thinking about you're going to have to see antibiotics and working that way. I try to do local first before I do anything systemic, but in some of your countries, you're going to have patients come in that never had anything done, and it's going to be a massive systemic problem. So yeah, get them on the Winkelhoff cocktail right away, and then start your treatments is the best way to kind of grab it all at once. But depending where you're at, I tend to like to look to see what the problem is first and not do over treatment. And I know a lot of people could get into that over treatment, and I tend to be very conservative first and say, right, let's just go step by step and take it that way and kind of go along that way. So, well, thank you very much for those of you who tuned in. This was fun. I hadn't done a lecture for a while. I'm just finishing up my dissertation, my PhD, so this has been really fun. I hope I helped you guys. And yeah, so I'm sure with Carrie you could look at the course again. And if you have any questions of anything further, my email is traceylennemann@hotmail.com. Feel free to send me an email and say hi. Thank you very, very much, and have a great evening and a Merry Christmas to everybody too.
We would like to thank our speaker for sharing her knowledge and expertise with us today. We would also like to thank our sponsor for making this online course possible, and thank you, our wonderful audience, for your interest and participation. The CE quiz is now available online on the course page, and completing it will allow you to earn your ADA CERP CE credits. The recording will be posted online within the next 48 hours. You will receive an email notification with a link to the recording. Thank you again, take care, and goodbye.